stomach acid, pepsin, and gastric secretions. Welcome to this comprehensive overview of stomach acid, pepsin, and gastric secretions. Understanding these fundamental components of digestion is essential for grasping how our bodies break down food and absorb nutrients. The stomach's acidic environment and enzymatic activity play critical roles in both digestive health and disease prevention. Stomach acid serves multiple vital functions beyond simple digestion. Its clinical significance cannot be overstated. The highly acidic environment of the stomach, with a pH as low as 1 to 2, creates conditions necessary for activating digestive enzymes, breaking down proteins, and defending against pathogens. This acidity is fundamental to proper nutrient absorption and maintaining gastrointestinal health. The stomach produces several key secretions that work together to facilitate digestion. These include hydrochloric acid, pepsinogen, which converts to pepsin, intrinsic factor for vitamin B12 absorption, and mucus for protection. Each secretion has a specific role, and their coordinated action ensures efficient digestion while protecting the stomach lining from damage. Why does the stomach maintain such a low pH? There are several critical reasons. First, the acidic environment activates pepsinogen into its active form, pepsin. Second, it denatures proteins, unfolding them to make them more accessible to enzymatic breakdown. Third, it provides antimicrobial defense, killing most bacteria and pathogens that enter with food. Finally, it enhances the absorption of minerals like iron and calcium. Gastric acid secretion occurs in 3 distinct phases, each triggered by different stimuli. The cephalic phase begins before food even enters the stomach, triggered by sight, smell, and taste. The gastric phase occurs when food physically enters the stomach. The intestinal phase provides feedback regulation as partially digested food enters the small intestine. Understanding these phases helps explain how our bodies anticipate and respond to meals. The cephalic phase demonstrates the powerful connection between the brain and stomach. Even thinking about food can trigger gastric secretion. Sensory stimuli activate the vagus nerve, which signals the stomach to begin producing acid and enzymes. This preparatory response ensures the stomach is ready to receive and process food efficiently. Disruptions in this phase can affect overall digestive function. During the gastric phase, food entering the stomach triggers both mechanical and chemical stimulation. Stomach distension activates stretch receptors, while proteins and amino acids stimulate gastrin release. Gastrin is a hormone that powerfully stimulates acid secretion. This phase represents the peak of gastric acid production, with multiple feedback mechanisms ensuring appropriate secretion levels. The intestinal phase acts as a negative feedback system to control acid secretion. As acidic chyme enters the duodenum, it triggers the release of hormones like secretin and cholecystokinin. These hormones inhibit gastric acid secretion, preventing excessive acidity in the small intestine. This regulatory mechanism protects the intestinal lining and optimizes conditions for nutrient absorption. Pepsin is the stomach's primary protein-digesting enzyme. It is secreted as an inactive precursor called pepsinogen by chief cells in the gastric glands. When pepsinogen encounters the acidic environment of the stomach, it converts to active pepsin. Pepsin then breaks down proteins through hydrolysis, cleaving peptide bonds to create smaller peptides. When chyme enters the duodenum, the higher pH inactivates pepsin, preventing damage to the intestinal lining. Pepsin activity is highly dependent on pH levels. It functions optimally at a pH between 1.5 and 2, which corresponds to the normal acidity of the stomach. As pH increases, pepsin activity decreases dramatically. By pH 7, pepsin is essentially inactive. This pH dependency has important clinical implications, particularly in conditions like gastroesophageal reflux disease, where pepsin can damage the esophagus when acid reflux occurs. The parietal cell is the acid production machinery of the stomach. These specialized cells in the gastric mucosa contain proton pumps that actively transport hydrogen ions into the stomach lumen. The process requires significant energy and involves the exchange of hydrogen ions for potassium ions. Chloride ions are secreted alongside hydrogen ions to form hydrochloric acid. This sophisticated cellular mechanism can achieve a 1,000,000-fold concentration gradient. Acid secretion by parietal cells is regulated through three primary pathways. Histamine acts through paracrine signaling from nearby enterochromaffin-like cells. Gastrin acts as an endocrine hormone released from G cells in response to food. Acetylcholine acts through neurocrine signaling from the vagus nerve. These three pathways converge on the parietal cell, and their combined effect is greater than the sum of their individual effects, demonstrating synergistic regulation. Despite producing such corrosive acid, the stomach protects itself through multiple mechanisms. The mucus bicarbonate barrier creates a protective layer on the stomach lining, with mucus trapping bicarbonate ions that neutralize acid. Prostaglandins enhance this protection by stimulating mucus and bicarbonate secretion while maintaining blood flow. Rapid epithelial cell turnover replaces damaged cells every few days. When these protective mechanisms fail, ulcers and gastritis can develop. Hypochlorhydria, or low stomach acid, has significant clinical consequences. Reduced acid production impairs protein digestion, leading to malabsorption of amino acids. It decreases the absorption of minerals like iron, calcium, and magnesium. The loss of antimicrobial defense increases susceptibility to infections. Bacterial overgrowth can occur in the stomach and small intestine. Vitamin B12 deficiency may develop due to impaired intrinsic factor function. These effects can cascade into broader health problems. Common causes of hypochlorhydria include several categories. Medication-induced causes include proton pump inhibitors and H2 receptor antagonists used for acid suppression. Age-related decline in parietal cell function is common in older adults. Autoimmune conditions like pernicious anemia can destroy parietal cells. Helicobacter pylori infection can damage the gastric mucosa. Chronic atrophic gastritis leads to progressive loss of acid-secreting cells. Identifying the underlying cause is essential for appropriate management. Gastrin is a hormone that stimulates acid secretion, but its levels are regulated by stomach acid through negative feedback. In normal function, gastrin stimulates parietal cells to produce acid. When acid levels are low, as in hypochlorhydria or with proton pump inhibitor use, gastrin levels rise in an attempt to stimulate more acid production. Conversely, when acid levels are high, gastrin secretion is suppressed. Measuring gastrin levels can help diagnose various gastric disorders, including Zollinger-Ellison syndrome. Diagnostic considerations for abnormal gastric acid production include several approaches. Gastric pH monitoring can directly measure stomach acidity. Serum gastrin levels help identify hypergastrinemia or hypogastrinemia. The Secretion stimulation test can diagnose gastrin-secreting tumors. Pepsinogen levels in blood correlate with gastric mucosal health. Helicobacter pylori testing is important since this infection affects acid secretion. Endoscopy with biopsy allows direct visualization and tissue analysis. These tools help clinicians identify and manage gastric disorders. Clinical applications focus on optimizing gastric function for better health outcomes. For patients with hypochlorhydria, supplemental betaine HCl may improve digestion. Addressing underlying causes like H. pylori infection is crucial. Minimizing unnecessary acid suppression medication prevents iatrogenic hypochlorhydria. Supporting protective mechanisms through prostaglandin-sparing approaches helps prevent ulcers. Dietary modifications can support healthy gastric function. Personalized approaches based on individual assessment yield the best results. This module connects to several future topics in the course. Module 2 will cover peptic ulcer disease and its relationship to acid-pepsin imbalance. Module 3 explores gastroesophageal reflux disease and the role of acid in esophageal damage. Module 4 examines pharmacological management of acid-related disorders, including proton pump inhibitors and H2 blockers. Module 5 discusses nutritional implications of altered gastric function. These interconnected topics build a comprehensive understanding of gastric physiology and pathology. In summary, gastric acid and pepsin are essential for proper digestion and health. The stomach maintains a highly acidic environment through sophisticated cellular mechanisms. 3 phases regulate acid secretion: cephalic, gastric, and intestinal. Pepsin requires an acidic pH to function optimally in protein digestion. Protective mechanisms prevent the stomach from digesting itself. Hypochlorhydria has significant clinical consequences that extend beyond digestion. Understanding these principles is fundamental to clinical practice and patient care. Thank you for your attention to this important topic.